Hello, and welcome to today's Anticoagulation Forum webinar. As you probably know, we had the Anticoagulation Forum meeting in DC earlier this month. It was a great time. A good time was had by all. Great seeing some of you folks that I don't get to see very often at that meeting. At that meeting, we had a number of abstracts that were presented from a number of researchers, student researchers, residents, established folks. And we thought that we put together a webinar highlighting what we felt were some of the strongest of those webinar, or excuse me, of those abstracts and posters. So today we're going to be highlighting 4 projects. Next slide. I'm Arthur Allen, Anticoagulation Program Manager at the VA Hospital in Salt Lake City and a board member of the Anticoagulation Forum. I'll be moderating this with my lovely and talented co-moderator, Naomi Yates, Manager in Clinical Pharmacy Services, Outpatient Pharmacy Services, and Kaiser Permanente, also on the Board of Directors. We have 5 presenters today. We will be hearing from Rachel Tang, who is a student researcher at University of Michigan. Katie Dane, clinical pharmacy specialist and benign hematology and cardiology co-director, hemostatic and antithrombotic stewardship at Johns Hopkins. We have Harriet Kusi, internal medicine clinical pharmacy specialist at MedStar Georgetown University Hospital. Amy Ives, assistant professor, University of Maryland School of Pharmacy, and Nghi, clinical pharmacist specialist, adjunct clinical assistant professor, ambulatory cardiology and anticoagulation management at Michigan Medicine University. And we will go ahead and get started here. I'm going to hand this over to Rachel Tang to hear from the first project, parenteral bridging practices and outcomes in patients on warfarin for mechanical heart valves and venous thromboembolism. Rachel, take it away.
Thank you, Arthur. Hi, my name is Rachel, and I'm an undergraduate senior at the University of Michigan. And this year I did a research project with Nghi on, like you said, bridging practices and outcomes in patients on warfarin for MHV and VTE. So a little bit of background, perioperative bridging has traditionally been used for patients on warfarin during procedures aiming to prevent thromboembolic events. However, the bridge study in 2015 showed that bridging increased bleeding risk without clear benefits in preventing thrombosis. As a result, guidelines like the 2024 AHA and 2022 CHEST updates now recommend against routine bridging in most patients. That said, for higher risk groups like patients with MHV or VTE, the evidence base is still less robust. Our study had 2 main objectives. First, to analyze how often bridging occurs in patients on warfarin for MHV or VTE. Second, to compare outcomes, specifically bleeding and thrombotic events, between bridged and non-bridged patients. We use data from the Michigan Anticoagulation Quality Improvement Initiative, MACI, registry. That is a 6-center collaborative supported by Blue Cross Blue Shield of Michigan. We included patients on warfarin for MHV or VTE who had at least 1 procedural interruption between January 2020 and July 2024, with at least 30 days of follow-up. We excluded patients who were on warfarin for other reasons, such as AFib, or who were bridged with non-heparin agents. Interruptions were classified as bridged or non-bridged, naturally, and we analyzed results at 30 days post-procedure. To minimize bias, we used propensity score matching to balance patient characteristics between groups. We also used a generalized estimating equation approach to account for patients with multiple interruptions. So on the right, the standardized difference plot compares baseline characteristics between the bridged and non-bridged groups. In total, 293 patients were matched in each group. So the red asterisks are before matching, and then the open circles were after matching. As can be seen, there were substantial imbalances in several variables before matching. In particular, non-bridged patients had higher risks of CKD and diabetes, while bridged patients were younger in age. After matching, the differences for all covariates moved much closer to 0, as shown. with most falling well below the 0.1 threshold. This indicates that matching was successful in achieving good covariate balance between the groups. So about half of all warfarin interruptions in our sites were bridged, specifically 52.5%. This shows that despite evolving guidelines, bridging still remains common in this higher risk group. And then looking at outcomes, bleeding events were significantly higher among bridged patients. And just as important, there was no statistically significant reduction in thrombotic events among bridged patients compared to non-bridged patients. These findings were consistent even after adjusting for baseline differences. These are the after adjustment results, and accounting for repeated measures within patients. So in summary, bridging significantly increased bleeding risks. There was no significant reduction in thrombotic events during the 30-day post-procedure period. These results reinforce current recommendations. Bridging should be avoided in most patients, even in higher risk groups like those with MHV or VTE, unless there's a clear individualized reason. Further research should be done or is needed to be done to better define specific scenarios where bridging may still be beneficial. Okay, thank you. If there's any questions, I'd be happy to try to answer them. Arthur?
Thanks, Rachel.
Mhm.
Yeah, there were some questions that were sent in, which
Okay.
we can save for later. But I did want to say congratulations on the project. This
Thank you.
is significant for us. It helps to provide more information regarding whether we should be bridging in these patients. I am wondering whether, and we can take some time if we need to wait until then, but whether you looked at the mechanical heart valve and VTE patients separately, or were they all just lumped together?
Yeah, even at the conference in person, that was a pretty big question. I think that would be a very important further step or future direction for the study. But no, we looked at results of both the MHV and VTE patients together in this study.
Mhm. Yeah, thank you. I think most of us probably consider heart valve. We get a little more nervous, I think, about how heart valve patients versus VTE patient, particularly one where the VTE occurred more than a year ago.
Mhm.
Yeah, thank you.
Well, and I may have missed this as part of your presentation, but did you did you give us numbers on what the percentage of patients that were in the heart valve category versus the VT category?
Yes, I can go back if that's okay. But you can see here, you can see the prior VTE as a comorbidity, and then there's also stats on, oh, here, on the heart valves. And we also, even though we looked at the results all together, we also showed how many of our patients had mitral valves versus aortic valves. And I know that was kind of another question a lot of people had, or a lot of researchers had. But yeah, just looking at these individual groups might be beneficial as a future direction.
So despite current guidance, those the majority of your patients, if I'm reading this correctly, actually had VTE as their diagnosis and underwent bridging, as opposed to what I might expect to see would be a significant portion of mechanical heart valves being bridged, which is still a questionable practice,
Yeah,
and that lower percentage of VTE. So it seems like there's a real opportunity there to try to move folks away from bridging in this VTE population,
right.
kind of as the lowest hanging fruit.
Yeah.
Very interesting.
There is a question that was just submitted
Mhm.
saying, thank you, Rachel. Could you expand on potential individualized reasons why one would still pursue bridging since your data has already included high-risk thrombotic scenarios? So in which patients might we still consider bridging?
Yeah, that's a great question. Thank you. I talked with one physician at the conference, and I think he made a really good point. He basically his kind of feedback was that not all heart valves are created equally, and a lot of our patients, since this was more of this study had data from 2020 to 2024, a lot of our patients had newer model heart valves. But then there still are those patients with older heart valve models, and maybe we didn't kind of go into the different types of mitral or aortic heart valves. So I know there's a lot, I'm not an expert in this, but I know there's a lot of different types of heart valve models, and some can be more thrombotic, I guess would be the right word, or something like that. Yeah, so I guess it just really depends case by case. Yeah.
All
Thank
right.
you.
We had a couple of other submitted questions, but I think we'll save those for the sake of time. We'll save those to the end, and let's go ahead and move on to the next presentation so we get through all of them.
Okay, sounds good. Should I switch over to Katie?
If you could actually just stop sharing and Katie
Okay,
share her own.
sounds
Thank
good.
you. All right, so we'll be hearing from Katie Dane on their project on evaluation of direct oral anticoagulant eligibility and prescribing for primary venous thromboembolism prevention in high-risk ambulatory patients with cancer. Katie.
Thanks, Arthur, for the introduction. It's a pleasure to have the opportunity to share with you all our research project findings, and I would be remiss to present this data without acknowledging the rest of our project team, in particular, Michelle Wasson, who really led this project as a PGY2 oncology resident at JHH last year. So as you're all well aware, cancer-associated thrombosis is common, occurring in up to 15% of patients with a diagnosis of cancer, and it's also associated with significant morbidity, including increased ED visits, hospitalizations, reduced quality of life, delays in cancer treatment initiation, and even death in a portion of patients as well. National guidelines now recommend consideration of primary VTE prophylaxis in patients who are considered to be at risk for VTE based on VTE risk assessment stratification using the Khorana score. And these recommendations are based on the results of the Cassini and AVERT trials, which demonstrated the benefits of reduced dose rivaroxaban and apixaban for this indication. Despite these studies being published over 7 years ago now, implementation rates of primary VTE prophylaxis in clinical practice remain quite low. And so with this in mind, we conducted a retrospective study at 3 sites within the Johns Hopkins Health System. Our objectives were to characterize primary VTE prophylaxis prescribing patterns and VTE event rates in patients who were eligible for but not prescribed prophylaxis within 6 months of their initial cancer diagnosis. We included adult patients with newly diagnosed pancreatic cancer over a 1-year period, and we excluded patients who were not pursuing cancer treatment initiation, those who had a Khorana score below 2, so essentially patients deemed low VTE risk, patients who were receiving therapeutic anticoagulation at the time of diagnosis, as well as those who were considered to be high bleeding risk, which we defined as the presence of brain metastases, thrombocytopenia with a platelet count of less than 50,000, or experiencing hemoptysis at diagnosis, the latter of which was included because we do plan to do a second phase of this project in which we'll evaluate the lung cancer patient population where hemoptysis may be a more common presenting symptom. There were a total of 171 patients assessed, and 31 had an exclusion to primary thromboprophylaxis initiation, which was predominantly a pre-existing indication for therapeutic anticoagulation. Of the 140 patients who were eligible for prophylaxis in general, only 2 had a DOAC contraindication, both of whom had severe renal impairment. So this left 138 total DOAC eligible patients. The median Khorana score for this group was 2, and of the 138 DOAC eligible patients, only 1 patient was prescribed thromboprophylaxis. This graph shows cumulative VTE incidence over the 6-month follow-up period, with death included as a competing risk. The 6-month incidence of VTE in patients who were eligible for but not prescribed thromboprophylaxis was 32.6%. Interestingly, these events occurred pretty consistently throughout the treatment period rather than upfront immediately after diagnosis, which is known to be one of the highest risk periods for VTE. So we do need to further assess in this cohort whether specific triggers may have been present for this unusual pattern, such as hospitalizations or surgeries during that period of time. We also characterized the nature of VTE events identified during the follow-up period. The majority of VTE events were pulmonary embolisms, and over half of these events were symptomatic. So there were certainly potentially devastating events that occurred, some of which may have been avoided with use of primary thromboprophylaxis. So the major conclusions from our study were that 81% of patients in our cohort of patients with newly diagnosed pancreatic cancer were eligible for DOACs for primary VTE prevention, and only one of these individuals was prescribed thromboprophylaxis. Approximately 1/3 of patients eligible for DOAC prophylaxis experienced a VTE event during follow-up, the majority of which were symptomatic PEs. So next steps for us are to work with our GI oncology faculty to implement a pilot involving the use of standardized screening criteria for DOAC eligibility, as well as VTE risk assessment using the Khorana score, with an optional consult to a hematologist or hematology pharmacist for complex cases. And in tandem, we'll perform the same study in the lung cancer population at JHH. And with that, I'm happy to discuss further and answer any questions you may have now or during the Q&A.
Thank you, Katie. That was awesome. Naomi, did you have any thoughts on this project?
Yeah, I really appreciate it because we know that our cancer patients are higher risk for VTE, but also higher risk for bleeding. So we do have several questions coming in, and maybe we can take a few of them now and then try to save some of them for the end. Thank you guys for sending the questions into Q&A. We were not expecting so many. You had mentioned about trying to consider next steps in terms of how you might be able to help the GI oncology faculty to be able to implement. I'm wondering if you had considered at all the use of clinical decision support, or what you're considering in terms of utilizing standard screening criteria and how to implement that.
Yeah, that's a great question. Something that we discussed a bit amongst our group. I will say one of the more successful, maybe even the only successful way that I've seen to address this issue is, I think was published by the University of Vermont, where they actually embedded the Khorana risk assessment score in their EMR. And so I think that that really is something we'd like to pursue, but of course, those types of large scale changes within our EMR Epic take quite a bit of time. So our thought was that we would first trial this pilot to hopefully increase interest in doing this more broadly, and then if we're able to successfully show that this has a positive impact, then perhaps that would be good ammunition to prioritize adding the Khorana score into the EMR. But for the time being, we're thinking that we're going to use a Epic dot phrase of some kind to provide that to the GI oncology group so that they have standardized screening criteria they can use. And then we can also easily then pull that information for a post pilot assessment as well.
Mm-hmm.
Thanks for doing this project. I tell you, when the trials were first coming out and the guidelines were first changing, I tried to approach my hemonc folks about this, and what I found that folks tend to kind of be all or none with this. The same is kind of true for extended VTE prophylaxis for the medically ill. They're either like, we don't believe in that, or we do believe in that. But what needs to be happening is individual patient evaluation. And so I tend to, what I'm seeing is this all or none approach of, because we don't, we kind of don't do that, then we don't ever think about it even when we should be. So the fact that you guys look specifically at pancreatic cancer is interesting. Obviously the, evaluation should go beyond pancreatic. But I agree that the only way to get at this is going to be probably through clinical decision support that's embedded, to make it just be part of something that they think about. So strong work on this. Naomi, is there maybe one more question or anything we want to address before we move on?
Yeah, there's one question about barriers. What do you believe were the most significant barriers that could be addressed, or has there been consideration to approach the providers themselves to inquire about that?
Yeah, great question. So we didn't include a formal assessment of barriers for this project. That would have been, in hindsight, something that would have been great to include. We did sit down with our GI oncology faculty and review these results with them. And I would say it was a mixture of opinions, kind of what Arthur alluded to. There were a few individuals who were very in favor of it. And then actually the majority of the group was less in favor of it because of a combination of, limited knowledge about this area of practice or comfort with performing risk assessments. And then also some who argued that because there's not been a mortality benefit shown with this intervention, that they were a little bit less interested in it. But I think that that's one of the reasons that, we're interested in doing this pilot, is to show what the impact of implementing this in their patients could be, so that we can hopefully, not have this be an individualized practice from a provider standpoint. It can kind of be, the standard of care amongst our provider group.
Yeah, I mean, it's a valid point, and in their defense, hemonc providers are so focused on the cancer itself, but I think that we tend to forget that the thing behind cancer that kills cancer patients more than anything else, other than the cancer itself, is VTE. And so it's extremely important to keep these kind of things in mind. All right, we'll go ahead and pull this slide down, and we'll move on to our next project. Again, if you have questions about this one, please submit it in the Q&A, and we'll try to have a Q&A session at the end. We should have time for that. So we're going to keep on moving here. We'll put up the next deck. All right, and if we could go into presentation mode, that would be great. So we are going to be hearing from Amy Ives and Harriet Kusi on their project, Assessing the Impact of an Inpatient Anticoagulation Stewardship Program. Take it away.
Thank you, Arthur. We're very happy and we're very pleased to be able to share our research with everyone. As we all know, the anticoagulants are high-risk medication associated with a number of events. So the 2019 Joint Commission National Patient Safety Goal really emphasized reducing harm associated with these medications. We had a pretty successful pilot program done in our institution within 2021. And so as a result of that, we implemented an inpatient anticoagulation stewardship program in January of 2021. The primary objectives of our research was to assess the effectiveness of that stewardship program on medication error reduction, and then also analyze pharmacist interventions and 30-day readmission rates for bleeding and clotting. This was a single center retrospective study. We actually looked at 2 time periods. We had a pre-implementation period of March to May of 2020, and then post-implementation period of March to May of 2021. We included patients who were on oral anticoagulants, in addition to fondaparinux, and therapeutic doses of enoxaparin. We excluded patients who were on prophylactic doses of enoxaparin and unfractionated heparin, in addition to heparin infusions, and then also pediatric patients, which we defined as less than 18, and our patients in the labor and delivery ward. So we had about 525 patient data that were assessed. 463 met inclusion criteria. And of these, about even amount in each group. So we had about 236 in our pre-implementation group, and then 227 in our post-implementation group. Just going over a little bit of the stewardship pharmacist workflow. We had a daily report that would generate for us Monday to Friday. So the pharmacist will review the report and review the patient charts who are on active anticoagulants. They review the progress note and then assess for any appropriateness in dosing or inappropriate regimen, any drug interactions, and document an intervention in each patient's chart. In addition to that, the pharmacist would notify the prescribers with any recommendations and would follow up the next day just to see if the recommendations were implemented. So Amy now will go over the results and outcomes.
Right this very second, it's frozen, of course. Oh, come on. So switching gears to our results, looking at our patient demographics, you can see that the average age of our patients was mid-60s, predominantly female. When looking at the indications for anticoagulation, PE and DVT was the top diagnosis. This include both acute events and patients that came in the hospital on anticoagulation for this indication. Our second most common indication is atrial fibrillation, and the third was stroke. The numbers do not add up to 100% here because there was a smattering of other indications for anticoagulation, which we did not include. When we look at our data, apixaban is by far the most commonly prescribed anticoagulant at our institution, and this is borne out consistently in other data analyses that we have conducted with about 2/3 of patients receiving apixaban. The enoxaparin and rivaroxaban information is also there. The predominance of enoxaparin is likely due to the timing of when we intervened in the hospital setting. So not that the patients were going home on enoxaparin, but that they were on it at that point in time when we intervened. Looking at medication errors, in the pre-implementation phase, there were 21 documented medication errors and 9 in the post-implementation phase. This is a 57% reduction in medication errors. Characterization of these medication errors follows on this slide. When we look at dosing, either overdosing or underdosing, a medication error was defined as an improper dose based on renal function, based on indication, potentially based on drug interactions. Our number of contraindicated drug interactions has basically been eliminated through this program. Primarily, the contraindicated drug interactions that we were seeing were enzyme-inducing agents, and we now reach out proactively when we know that this is going to become a problem before discharge. We reach out to those teams and say, do you know you won't be able to use a DOAC in this patient? Let's troubleshoot this now. An omission is likely something that was missed on admission. So the patient through MedRec came in and was not continued on anticoagulation. We have a unique patient population at MedStar Georgetown in that we are an intestinal transplant center. So absorption is always a consideration for those patients. And contraindicated organ dysfunction, as opposed to dose change for renal function, is if an anticoagulant was prescribed below the accepted creatinine clearance for that anticoagulant. Looking at our interventions, in the pre-implementation phase, there were 13 documented interventions. This was an act of love to track down these interventions. At this time, this was back in 2020, we did not have a templated note or an organized program for either documenting or intervening on anticoagulants. That number went up in the post-implementation phase to 45 documented interventions over the 2-month study period. Despite the increase in the number of interventions that were documented, the number of accepted interventions remained similar between the two groups. And something that we found particularly intriguing was the impact on readmissions. In the pre-implementation phase, we had 31 patients that were readmitted within 30 days, and in the post-implementation phase, we had 13 patients. When you break that down further to readmissions related to bleeding, we had 5 in the pre-implementation group and 1 readmission related to a clotting event in the post-implementation group. Study limitations. It goes without saying that having to conduct a manual chart review to collect retrospective data is challenging and limiting. We had a very eager med student who worked with us for the summer, reviewing over 500 charts to make this data possible. We also learned a lesson there in terms of standardized definitions. Our term for intervention was, if the pharmacist intervened in a way that made a recommendation to the team, and that recommendation was either accepted or denied. Well, the medical student interpreted this as an intervention was any note that a pharmacist wrote related to anticoagulation, and not all of our notes are an intervention or a recommendation. So we have rigorously vetted the data a second time to make sure that that information was correct. And if there's any sister Cerner hospitals out there, you feel our pain with the data analytics. Despite the fact that this program has now been in place for more than 4 years, this is something that we are still challenged with to collect data in a manner that is meaningful and does not require a retrospective chart review. So in conclusion, our service has documented a reduction in medication errors by 57%. This is comparable to another study, which was a pharmacist to dose DOAC study, and the numbers are similar. We have noticed that over the course of the 4+ years that we've been doing this, providers are aware of our service and they reach out proactively. So they will be admitting a patient in the emergency room and say, hey, I've got this problem with this patient. What would you suggest that I do now? This has been particularly poignant when it comes to the drug-drug interactions and identifying those before the patient is ready for discharge. The decrease in readmissions, specifically for bleeding or clotting events, requires further investigation. Looking at our future directions, of course, data analytics is something that we continue to work on to streamline and be able to capture this information in a meaningful way. Our model for an anticoagulation subcommittee, it's a subcommittee of our Pharmacy and Therapeutics Committee, has been adopted on the system level. We are a 10-hospital healthcare system, and we are now working with all 10 hospitals for things like policies and procedures and data collection, things like that. We were inspired by Allison Burnett's talk on anticoagulation stewardship at the AC Forum in early April. We have not previously looked at cost savings as a method for increasing FTEs, but that's certainly something that we think would be useful in this setting. And lastly, we will be working towards educating all of our pharmacy staff in a competency-based manner. So these interventions can be the expectation of workflow for all pharmacists and not the individual anticoagulation stewardship pharmacists. At this point, I'd like to stop and entertain any questions.
Excellent, Amy. Thank you so much for that. I want to just pause on something you said real quick that I don't want it to get glanced over. You know, like the movie Field of Dreams, if you build it, they will come. And if you heard what she said the ER now knows who to call, and they have established themselves as a necessary service. And if we want to see stewardship grow and you want to see stewardship promoted, be what the place needs you to be what the facility needs, be that expert, be the voice of it. And you're doing that when they start ringing your phone. Naomi, what do you have for us?
Yeah, congratulations. This is amazing. You were able to reduce so many medication errors and readmissions. I'm curious about what types of interventions were made. Is it mostly dosing or anything else of significance that was interesting that you discovered?
So I think the interventions are primarily with the drug interactions and with dosing. So I'll give you an example. The patient who gets prescribed an initiation dose of apixaban 10 milligrams POBID for the indication of AFib. And that is one of the errors that's embedded in here. So I would say mostly it's dosing, and the dosing related to either medication reconciliation, renal function, or indication.
And just to add to it real quickly, I think with drug interactions, our infectious disease specialists typically sometimes like to use rifampin. So we were noticing this a lot, where the patients would come in DOAC and then somewhere during the hospitalization, they would prescribe rifampin and then restart the DOACs. So our proactive measures really help catch that before they discharge them to rehab and kind of make a change in anticoagulation for that therapy.
Awesome. Thank you. Another follow-up question. You mentioned about increasing FTEs. You're hoping to increase to be able to expand the program. What would these additional FTEs do? And what would be the limitation if you're not able to get the additional FTEs?
So that's a very excellent question. Right now, Harriet and I are the anticoagulation stewardship inpatient service. Harriet is a full-time FTE and I am a part-time FTE. Our goal would be to be able to roll this out for the staff pharmacists that are currently incorporate this into their current workflow. This is not currently something that they do. On discharge in particular, we know that there's a problem. We currently do not have the staff to do discharge education for every patient. The system that we've put in place now works, but it's not without its limitations. So every patient that's discharged on an anticoagulant is reviewed the next business day to make sure that the anticoagulant regimen was complete and correct on discharge. And if not, the team is notified for intervention. So again, somebody's looking at it, but it's kind of after the horse is out of the barn. So we would certainly want to utilize FTEs there. And I think an additional FTE for IT or data analytics in terms of being able to capture our data in a more robust manner.
Mm-hmm. And is it mostly manual chart review, or is there any use of decision support?
There is currently no decision support. Our drug-drug interactions we know are a disaster. And so it is a manual chart review for this intervention, for us to screen the patients to determine whether the anticoagulant and or the dose is appropriate.
Mm-hmm. Mm-hmm. So area of opportunity.
Yes, absolutely.
I would suggest that manual chart review for some of these things can be limited in scalability, and I would encourage looking into the use of population health or other data support to identify these things to do it for you. We've been involved in the Anticoagulation Forum and some projects looking at inpatient dashboards and that kind of thing. So I would point you to that stuff. But excellent work. We're going to keep moving here. If we can go ahead and pull those slides down, we'll get the next deck going, and then we'll come back again and we'll answer some questions on some questions on these projects. We're having a number of them submitted. All right. And so our last project going to be presented here today is from Nghi. Continued assessment of a direct, or speaking of dashboards, continued assessment of a direct oral anticoagulant dashboard. Take it away.
So thank you for the opportunity to share our experience with the implementation of a DOAC dashboard at our tertiary academic center. So just a little background, with the introduction of DOACs over the last 15 years, has really changed our approach to anticoagulation management, both in terms of therapy selection as well as monitoring. As an example, DOAC accounted for approximately 5% of market share in 2011. That number has increased to closer to 50% by 2020. With the shift of therapeutic selection from warfarin to DOAC, we needed a new management model to ensure optimal safety and efficacy in patients with DOAC. At Michigan Medicine, we implemented a DOAC dashboard within our EMR in 2021 to better target patients who may need our assessment based on their renal function, age, weight, indication, as well as significant drug-drug interaction. So prior to the implementation of the dashboard, our service operated under the referral system, where provider can refer patients to our service for therapy initiation as well as monitoring. Under that system, we managed approximately 1,000 patients at that time. In October of 2021, we activated the DOAC dashboard, at which time outpatient population grew from 1,000 patients to 10,500 patients. And that population has grown steadily, closer to 16,000 patients as of today. With the implementation of the dashboard, our service was able to manage a significantly higher patient population. In our case, providing full coverage to our monitoring service to the whole health system. So the objective of this project is to describe the DOAC dashboard as well as to evaluate the effectiveness of pharmacist management of alerts. We review all alerts between January of 2022 and January of 2024. Our outcomes included total number of alerts addressed, number of intervention needed, as well as proportion of intervention implemented. Looking at our results, we reviewed a total of 4,443 alerts during that period. Critical alerts accounted for approximately 27% of cases, and critical alerts is defined as alerts with patient having multiple anticoagulant on the medication list, patient on suboptimal dosing, as well as patient with significant drug-drug interaction. Possible critical alerts accounted for 73% of cases, and possible critical alerts are primarily alerts of missing information that is preventing the dashboard from making an appropriate assessment. This can be missing weight or lab values, status of patient heart valve replacement, whether it's prosthetic versus mechanical, as well as indication for DOAC or for anticoagulation. Looking at the results, all possible critical alerts were resolved by entering missing information into the chart. And then of the critical alerts, we had approximately 40% of cases where they require some form of intervention. So in order to optimize our approach, as well as to better target patients who may require our assessment and intervention, we wanted to see if there were any differences between patients who needed our intervention versus those who did not. Patients who require our intervention tended to be older, had poor renal function, had lower body weight, and had atrial fibrillation as their primary indication. There was no difference in the proportion of patients requiring our intervention between patient on apixaban versus rivaroxaban. Looking at effectiveness, approximately 75% of our intervention or proposed intervention were accepted by provider and patients and were implemented. We also want to take a closer look at patient with suboptimal dosing, as this category accounted for a major component of the critical alerts category. So in patient requiring a dose reduction, approximately 88% of proposed interventions were accepted. In those requiring a dose increase, a lower acceptance rate of 60% was observed in that population. We also want to look at the number of repeat alerts for patients, just because repeat alerts also add to our alert queue. And we found that approximately 15% of patients had repeated alerts, with an average of 3.3 repeated alerts per patient. And the majority of those repeated alerts involve inappropriate dosing due to fluctuating weight or renal function in patients with borderline parameters. So just to wrap up, the DOAC dashboard provided an efficient method of identifying patients on DOACs that require dose adjustment or other therapeutic modification. With the DOAC dashboard in place, we were able to provide coverage for a significantly larger patient population. And the DOAC dashboard is a crucial component of our overall antithrombotic stewardship program. Looking to the future, we aim to continue to resolve existing alerts to achieve the maintenance phase of the dashboard. The goal here is to clear up the backlog of alerts so that we can address new alerts as they come in real time. We also aim to continue to optimize our approach as well as our service through continuous program assessment as well as research. And then finally, we aim to continue to explore a multidisciplinary approach to the dashboard management. This is where we're trying to increase involvement from our nursing colleagues as well as learners to increase their participation in DOAC management. From a programming standpoint, we aim to optimize the prioritization tool within the dashboard to help the users better target alerts that are actionable. And then finally, we aim to expand our efforts to provide education to both providers and patients in terms of suboptimal dosing. With that, I would like to acknowledge my research mentee who did a lot of the work on this project, my co-investigator, our leadership team, our dashboard administrator, as well as Mackie for their statewide coordination. With that, I thank you for your attention.
Thank you, Nghi. I have a burning question for you for others who have seen your amazing work and want to implement it right away and get a dashboard at their site. What recommendations do you have for them?
So I think the biggest recommendation would be to have staffing in place before implementing something like this. Just because, as you can imagine, when we activated dashboard, there was a huge backlog of alerts that would come in, and we're still working on that backlog as of today. I know Jeff and the team is working to have the dashboard available to other health systems, and I think if other health systems are interested, they can email me or Jeff for more information about access to something like this. But I think the biggest barrier is just really having the FTE in place before starting something like this, just because you have to build that rapport with the health system, and addressing that initial flood of alerts is a challenge.
Yeah, we in the VA, when we have that that first initial flood of alerts, a lot of things that maybe has already been handled, we call that pulling the weeds. You have to go pull the weeds to get to what needs to be done. That brings me to one of the things that I noticed, that you had 75% or 73% of your what you called kind of possible clinical, and you said that they were all cleared up by missing data. What I'll say about dashboards is that they are only as good as the data. They are only as good as the data that they have in them to do the work. And so there's a potential, if you're not careful. The dashboard is designed to help us manage patients, but unfortunately, what can happen if you don't have great data is that you end up managing the dashboard. And so I guess the question that I would have would be, are there efforts in place to improve the initial data pull or anything to avoid the need to basically line up the data that you need for the dashboard to do its thing? Or is there do you see I guess I would ask, do you see the need to clean, if you will, the dashboard data as a kind of a rate limiting step in the ability to use a tool like this?
Yeah, absolutely. I think that's a really important point, and that's where the multidisciplinary team come into play. We try to expand that role to our administrative staff, as well as some of our nursing colleagues, to find that missing information. A lot of it is due to just not having connection with outside labs within our EMR, so having to track that down. So I think saving the pharmacists for addressing the critical alerts is kind of our main goal, and having the data searching component be pushed towards other staff member that can help with that, so that we can prioritize addressing the critical alerts.
And I'll tell you something so to answer the question that Naomi had, I'll tell you something very, very interesting. And at the exhibit hall at the AC Forum meeting, we often have seen diagnostics companies and pharmaceutical companies and that kind of thing. There was a shift this year. There were a number of software companies. And in fact, there was one of the software companies that is now promoting a commercially available dashboard product that they're kind of kicking off and starting after having worked with the Mackey group and what they've developed. So I think these tools will become more and more available. And for those of you that haven't followed this space, it's really impressive if you read the literature that's coming out of Mackey, that's coming out of the VA, on what you can do with these things. We now actually have within the VA dashboard evidence not only of improved likelihood of patients being on the right dose, which we kind of already knew, but we now have direct correlation between the dashboard used in the VA and outcomes. So very important. I would recommend that we go to there, or that you guys review the literature that's been published in this space. All right, why don't we go ahead and pull the slides down? Let's all go cameras on, and let's open up some chat about all of these fine projects. First, I'm going to suggest, by the way, that all of you pursue publication of these excellent projects. We need this out in the literature. The Anticoagulation Stewardship Initiative needs you. So I would say that. But Naomi, you have any questions for our project leads here?
We do, yes. If we can go back to Rachel. we had several questions asking how recent was the VTE?
Yes. So in our, I guess I can't really share my slides again, but I saw those questions and we just have kind of in our research, we only have indication for VTE, and then if they are indicated for anticoagulation for VTE, if they have had prior VTE, like prior to that. We don't really categorize between like how recent it was. So yeah, I hope that answers the question.
But so to be clear, you guys weren't making the bridge decisions. You guys were evaluating the work that others had done and made decisions on.
Yeah.
And they would have been taking into account time since the VTE history, scariness that had happened before, anything that helped them making the details about mechanical heart valves. So you guys are simply evaluating what other providers were doing, and so I wouldn't necessarily expect you to have those data.
Yes. We were only looking at clinical outcomes. We weren't deciding any of these cases ourselves.
Right.
Thank you. Do you have any information, Rachel, on the dosing of Lovenox that was used?
I don't believe we excluded patients with Lovenox. Any bridging agents that weren't heparin, we did not use.
Okay, thank you.
Yes.
Okay, this one is for Harriet and Amy. I'm trying to do rapid fire as we approach the end of our hour. Did you face barriers in terms of getting providers to accept the recommendations, particularly with the incorrect dosing?
So I would say over time that's improved dramatically. We've kind of proven ourselves. There are certain providers in specific specialties that tend to do things their own way. And I have a lot of respect for surgeons in particular. If you are spending 12 hours working on an organ, an artery, whatever, you deserve the opportunity to dictate what happens with anticoagulation. So in those situations, we recognize that they have a particular way of doing things, and that's going to be a low impact chance of success for us.
Mm-hmm.
Yeah, the old gestalt. Patient looks frail. Yeah.
Just to add a quick thing, I think initially we also had some challenges with patients who would be admitted on incorrect agents. So the contraindication was there, and then initiating conversation with the admitting provider that this is a problem and getting them to correct something that someone else inadvertently had created. But I think over time they've now, we've gotten their trust. They're more willing to take that chance. But it
Yeah,
was
that's
definitely a
a
challenge as
real
well.
valid point. I will give you guys kudos for so those that are attempting, correcting prescriptions from outpatients on the inpatient side, as well as the other place where I see this is, inpatient antiplatelet deprescribing initiatives.
Mhm.
For inpatient providers to be willing to change something that's happening in the outpatient setting, that is probably one of I would think, the hardest lifts. So, kudos to those of you that are actually successfully doing that, because, in the emergency department or during a, medically ill hospital stay, folks were like, look, I'm here for this thing that's making me sick and got them hospitalized. That's what I'm going to treat. Everything else. And so to be able to even approach that it takes real initiative, and it probably takes having a valued opinion and a valued just presence at the facility to say, no, really, this is wrong, or this is dangerous, or this needs to be addressed. And I don't care who made that decision. We need to be willing to overrule it. So kudos to everyone doing that.
So Nghi, do you have anything to add? I saw that there was a high denial rate too for some of the recommendations that were provided as a result of the dashboard for the denial of increased dose increase. There was 40% denial rate. Do you have anything to add on how to improve that?
Yeah, so I think a lot of it has to go back to patient education as well as provider education. Because I know previous studies have shown that patient may be aware of the increased risk for bleeding, but they may not be aware of their increased risk for thrombosis for being on a suboptimal dose. So
Mhm.
providing that education is important, and I think that will improve with time. And from our standpoint, it's important to note that we require both acceptance from provider and patient. So if a provider is agreeable to changing the dose, but the patient is not, then we can't really implement that intervention. So the education has to come from for both provider and patient.
Thank you for that. We have multiple questions, Nate, asking about what kinds of different components were in your DOAC dashboard, and maybe you could briefly share, and then we can provide your contact information if they have any follow-up questions.
You mean what component the dashboard incorporates into the?
Yes.
So it includes, it pulls in labs, so renal function, indication, the anticoagulation itself. It could be one or multiple. So some patients are in the transition phase and may have warfarin and a DOAC on their medication list. Significant drug-drug interaction, but with the DOAC dashboard, it's really limitless, right? So I think that's kind of our starting point. But with future direction, we can look at monitoring for increased risk for bleeding, inappropriate antiplatelet use, for de-escalation, things like that. So so as of now, it's mainly looking at appropriateness of dosing, but the possibility of the DOAC dashboard is significant.
Yeah, I can just speak to that briefly. And I would suggest those of you who are interested in the details of what these dashboards do, what the logic is. I know that Mackie's been good about publishing on this. That would have some detail probably about the logic. I know some of the stuff we've published from VA, if you go to the appendices, it includes some of the logic about what these tools do. So if you have specific questions, I would reference going back to those publications. If it's okay, I want to address one question that's somewhat unrelated to the projects, but there's been a couple of questions about APS, and so a lot of the questions we had about Rachel's project, about the details of the VTE, again, their group didn't make these decisions. They only had what happened to the patients, and those clinical decisions were made there. So we can't really address them, but I do want to address the question of APS bridging and that kind of thing. So number one. And then there's a question about DOACs for APS. Number one, the APS diagnosis has to be real. It often isn't. The APS diagnosis has to be appropriately evaluated for which antibodies, is it double positive, triple positive, that kind of thing. Yes, warfarin is favored for patients with true APS, certainly with triple positive or those with arterial presentations. But even there are enough literature to suggest that if the APS is real, regardless of how many antibodies you have, probably warfarin should be preferred. A shared decision-making approach should be taken beyond that. And then the question of bridging, there is no population ever on Earth that we've proven that bridging is the right thing to do for any population. There are those that make us super nervous, and there are those that we feel like a wide window of interruption that you get with warfarin, where we should probably favor shortening that window. But every time we study a population to evaluate if that's the right move, we find that it causes more bleeding and no therapeutic benefit. So should patients with APS be bridged? Can't prove that they can, or I can't prove that they should. But it's a high risk population that makes folks nervous. So I hope that helps. Did we have any other questions that we wanted to address? Just rapid fire, Naomi?
So there are more questions about the dashboard for patient weights and kidney function. Does your institution have a set or acceptable time frame for the date of these values? Meaning that the lab values what is an acceptable time frame?
So we try to aim it within the last 12 months. And then our staff also go back and try to update that if lab results are beyond that time point. One of the requirements of the dashboard is that the patient be managed by one of our providers within our health system. So because of that, they do have most of the case, they have a recent wait due to their clinical visits. Lab value is kind of a hit or miss. But with that, we try to aim it to be less than 12 months. And I just wanted to add, so if anyone has a question on the dashboard, they can feel free to email me. But we also published a paper on the initial rollout of the dashboard, and it has a lot of details in terms of barriers as well as what the dashboard addressed if people are interested in looking at that. But yeah, if I got a lot of questions during AC Forum, so if anyone has questions, feel free to email me.
Yeah,
Thank
excellent.
you.
Thanks, Nghi. Thanks, Naomi. So I will say this about the dashboard, about the importance of the timing of labs. It depends on your setting, and the outpatient setting is one thing. If you're trying to use an inpatient dashboard, the appropriate timing of labs will be something completely different. So we're at the end of our time. I thank you all so much. Thank you, Naomi, for helping moderate this and moderate the Q&A. I want to thank all of our speakers for these excellent projects, Rachel, Katie, Harriet, Amy, and Nghi. Again, encourage you to publish these findings. We need you. Next slide. I'm not sure who's controlling the slides. There we go. So moving on to AC Forum, stay tuned for updates to AC Forum. We have some exciting updates coming soon to the AC University, our online educational platform. There's going to be new learning modules and on-demand boot camp, the 2025 boot camp. More will be launching soon, all offering CE credits. And we'll keep our members informed with the latest launch details. So stay tuned. Also, don't forget about our Centers of Excellence program. If your organization isn't one of the 140 plus anticoagulation centers of excellence, would ask why. Consider taking the assessment. New assessment and updates to the ACE site are coming soon, but there's still time to complete the current assessment and secure ACE status for the next 3 years. And then our next webinar, you're going to have to see my ugly mug again. It looks like I'll be moderating the webinar highlights from the AC Forum 18th National Conference. Don't miss it, especially for those of you if you were unable to attend the meeting. We'll be highlighting some of the talks from that meeting, kind of the takeaways, what those of us learned and enjoyed from the conference. And at this time, I thank you all. Thank you for your time and for your attendance, and we will see you next time.
Thank you.